Hello, everybody. Happy Friday. Happy Friday. Did you see that? I have a graphic. Isn't that cool? I've been working on that for a while, so it's so exciting to be able to preview that to you guys. Well, guys, we are here in our continued state of lockdown with coronavirus. And for those who are just joining, I'm Dr. Cindy, Medical Director, Laboratory Director, and at the Nevada Fertility Institute, located right here in sunny Las Vegas, Nevada. I'm also a PhD trained virologist. And so, as part of coronavirus and messaging, I have been bringing you live videos with special guests addressing subjects and topics that are really relevant to our continued sanity and are being able to come out of this doing pretty okay, you know? So today, I actually have a really special guest joining us. It's Dr. Wendell Bobb. He is a triple board certified neurologist, sleep medicine specialist, and a physiologist who is right here in Washington, D.C. Guys, please join me in welcoming Dr. Bobb. And Dr. Bobb, hello, hello. How are you?
Doing pretty good, Dr. Duke. How are you doing?
I'm great. I'm so happy that we finally got to this because we've been writing this for about 8 months now.
Yes, we've been trying, but it worked out. Where there's a will, there's a way, right?
There's a way. And you know what? It's actually the perfect time because, of course, all dealing with COVID, for the majority of us, whether admit it or not, are sleeping disordered. We're not sleeping. And talk to you about so many things. Notice that COVID-19 is having neurological impact on people, and it seems recovery, sleep issues, and of course, have you start by telling us what exactly do you all these certifications? Tell us more about what you do.
So I'm a sleep neurologist. So I'm a triple board certified neurologist. So I specialize in neurology, sleep medicine, and clinical neurophysiology, which is essentially the study of the brain waves or the waves of the nervous system. So the brain waves, the spinal cord waves, peripheral nerves. And we try to use that information to help with a diagnosis or to help treat. One of the other things that I do besides sleep medicine is I do neurointraoperative monitoring. So during brain surgeries, during spinal cord surgeries, I monitor the evoked potentials of the brain waves to make sure there's no damage being done during those procedures.
Wow.
And to alert the surgeon in real time if there is. So sort of do good things.
So what was it like to become this? What was your course? You went to school, but tell us a little bit about how you arrived at it.
Sure. So during medical school, I was pretty fascinated with the brain and the nervous system. One thing I do remember, and you probably remember this, everyone said, you know, you gotta study neuroanatomy really well. It's not straightforward. So I just went into it to decide, let me just study every day to try to do as best as I can. And then I just found that it was really cool, that one side of the brain controls the other side of the body. And, there are a lot of behavioral manifestations of problems with the brain. So if there's something wrong with the reproductive organs, like, in your field, people tend to accept that, okay, if someone has a heart attack or some sort of cardiac problem, it's not taboo. But then you get higher up, and that same problem, if it happens in the frontal lobe or in other parts of the brain, it may manifest as a behavioral manifestation. And then it suddenly becomes taboo, or people may have seizures. And sometimes people may confuse it for some sort of paranormal or spiritual phenomenon. So I thought it was pretty fascinating, the brain and just how it works. And, so that's one of the reasons that I got into neurology. And then I did my 4-year neurology residency at Georgetown. And, again, just really confirmed that this was what I was supposed to be doing. And there's so many neurologic disorders. And now, thankfully, in 2020, we can do a lot about many of them. You know, there's still ways to go, such
Yes.
as Alzheimer's or, you know, healing Parkinson's, different things like that. But, you know, we have come a long way in terms of treatment. And then I also wanted to subspecialize. So I did, as you mentioned, clinical neurophysiology, but then I also did sleep medicine, for which I'm really passionate about. And one of the reasons I'm passionate about sleep medicine is so many sleep disorders are misunderstood and underdiagnosed.
Yeah.
For example, sleep apnea, you know, people just don't know that it exists, a lot of people, but it affects so many other parts of our lives, you know, our
Yeah.
mood, our immunity, so many different things that people just aren't aware of. And, you know, we are so used to this truism that goes, you know, I'll sleep when I'm dead, you know, and sometimes people tend to correlate sleep with laziness or
Right.
not, you know, being productive. But
Mm-hmm.
the opposite is true. We need sleep in order to be productive, in order
Yes.
to be alert, in order for our bodies to be healthy. And that's one of my passions, to get the word out about the importance of sleep. And we're learning so much more about it because we have so many large studies that have been replicated that have demonstrated the importance of sleep.
Yes, and that's part of why I reached out to you last year. I know you know this, and why I wanted you to come today, because sleep is critical even in my field. So we know that sleep and hormones go together like, bacon, salt, fish.
Yes,
Dr.
yes.
Bobb is also from the Caribbean. He's from my home country, actually, Trinidad and Tobago. So
That's right.
I just had to plug it there. But really, they go naturally, and yet people don't realize how important sleep is, how it affects your hormones, affects your thyroid, your ability to gain weight or lose weight. And so it's going to be such an amazing conversation. Looks like we're already getting lots of comments that I'm sure to go through. So let's talk a little bit more about some of what you alluded to already. Sleep and its importance. Why is it that dare I say, why do mammals sleep? Why do we sleep?
So that's a pretty good question. So there are two main functions of sleep. One is as a restorative process to help, you know, restore, replete those cells, you know, the parts of the cells that have been depleted during the daytime while we're awake, but also for memory processing, converting short-term memory to long-term memory. Now, why do those have to happen during sleep? We don't know. You know, there have been decades and decades and centuries of studying to find out why we really need it. And you know, there have been some theories as to maybe we need to just an energy balance and different things. So we don't know exactly why, but we do know that they're very important functions in sleep.
Yeah.
So the first one, as I mentioned, as a restorative process. So the body during sleep, it's very interesting. In 2012, there was a fascinating discovery called the glymphatic system. Now, when we were in medical school, we all learned about the lymphatic system, which is a system that goes alongside the blood and the tissues to help exchange, you know, to get rid of waste products from the cells, and also to help transport vital nutrients and oxygen to the cells.
Yes.
But we did not know that this existed in the brain. No one had been able to prove it. And it just sort of went to the lower part of the brain. But in 2012, they discovered this glymphatic system. And essentially what it is that it removes the waste from the brain, the toxins that are produced. And why am I bringing this up in a sleep talk? Well, they found that this glymphatic system is turned on only during sleep. So during the day, its efficiency is decreased by 90%.
Wow.
So this is why one of the reasons sleep is important, because all of these waste products that build up during the daytime, they need to be gotten rid of at night. And one particularly important waste product is known as beta amyloid. And what's the significance of beta amyloid? That protein has been implicated in Alzheimer's disease.
Mm-hmm.
So it is crucial that that protein gets eliminated. And in 2018, the NIH had a very large preliminary study in which they noted that Alzheimer's is linked to decreased sleep. And we now have an idea why that is, because the glymphatic system is turned on during the night, while we sleep. So it is important for us to have sufficient sleep, at least 7 hours a night, to help reduce the risk of Alzheimer's disease and for a lot of those other metabolic buildup. So that's one for restoration. And then so also growth hormone, that's another hormone that's released during sleep. That also helps in repair and just building up the cells, replenishing it with glycogen and building up the proteins, those necessary components for our cells to function well. So
you can clean the house, energy, almost like bringing in the groceries for the brain. Glycogen is your sugar store.
Exactly.
Yeah.
We need that. That's how our brain thinks, and energy, the glycogen, all those things that you mentioned.
Yeah.
So again, that helps with the building back up and the repair, so that can happen during the night, so we can wake up feeling refreshed and alert, and in good moods, and being able to think clearly. And so that's exactly right. It definitely needed for that.
Wow.
So the restorative properties, so that's one. But the second major one is during sleep, we have for memory processing, converting short-term memories to long-term memories. So information that we gather by listening carefully or by reading, that gets encoded into a part of the brain called the hippocampus. And the hippocampus is in the temporal lobes. And actually, I have a model of a brain like right behind here. So
let's do it. Yes. So those who are listening know I'm a huge fan of the hippocampus and the amygdala. So
yes,
guys, see what it is I've been talking about.
You got it. So this is the temporal lobe around here. So deep to that, like much further back, we have the hippocampus. And the hippocampus is important in memory. So you have two main types of memory, declarative memory and non-declarative memory, or implicit memory and explicit memory.
What does that mean?
So excellent. So declarative memory are really recalling the ability to consciously recall facts and events. Okay, so we're able to consciously recall that, and that's grouped as declarative memory. And that memory is really what happens during sleep, during the non-REM stage of sleep. And I'll get into non-REM, but sleep is broken up into two main categories: non-REM, and which we have like deep sleep, and REM sleep, where we have rapid eye movements or dream sleep. But in the non-REM or the non-dream sleep, they've noted that these encoded memories, there's repeated reactivation of these this information, and this happens during the slow wave sleep. So this is then integrated into a pre-existing knowledge circuit, so that we're able to recall those memories and to efficiently use them. So several studies have shown that when two groups of people learn the same thing, but then the night after, or that same night, they're sleep deprived, 2 or 3 days later, they've noticed that they have not had the same recollection as those who've had sufficient sleep. And not only with that, we're able to also measure it with functional MRIs, where we can see parts of the brain that light up and that are active. And we also have the EEG, which tells us the brain waves and the stage of sleep. So we're able to prove that that's why these type of memories are important and occur and are solidified during non-REM sleep. And then
for our students and teachers who are listening, and parents, this is why sleep is important, huh?
Exactly.
Wow.
Exactly. It's crucial. And then the other type of memory, primarily we have the implicit type memory. And this has to do with procedural type things, acting out things, or motor skills. So learning to play the piano or some type of instrument, learning to ride a bike. These types of
performing surgery.
Exactly. There you go. What you do, right? In surgery.
Yeah.
Exactly. Exactly. So that type of memory occurs or is pretty much supported by REM sleep, rapid eye movement sleep. Okay, and they've noted that this part of the, these parts, certain parts of the brain, such as the basal ganglia or the cerebellum, which have to do with coordination and things like
That's
that,
the
or
lower part to the back. Yeah.
exactly the lower back
Mhm.
around here, if you can see this
Yes.
model.
So just above the brainstem, so to speak.
Exactly, you got it.
Okay.
Hopefully
Mhm.
that wouldn't fall on us,
Yeah.
but it's just a model. But anyway, so those are the two main functions of sleep, and of course, there's dreaming, which we probably
Why do
many
we
of us
dream?
exactly. So
People
many of
ask
us
that
should
all
have.
the time. Why do we dream? And should we
Why do
believe
we
in them?
dream? Exactly. So Sigmund Freud, Austrian neurologist back in the 1800s, early 1900s, he's like known as the father of psychoanalysis.
Yeah.
And he said that one of the reasons we dream or dreams are an expression of suppressed desires that we aren't
Yeah.
really able to express. Now, we're not, the reality is we're not sure. And of course, there are
Mhm.
many, people who believe that dreams are some sort of communication from, the supernatural or those who passed on or different things or some sort of
Yeah.
vision into the future. Um, but as neurologists and as neuroscientists, we're just not sure. We certainly believe that dreams occur because there's a lot of neuronal activity going on in the cortex during sleep. And we believe that a lot of these circuits going from the temporal lobe, which has to do with memory and just recalling things, is linked to the occipital lobe. So, but it bypasses the occipital lobe has to do with vision.
Accurate.
It's in
Yes.
back. You got it. And it
Mhm.
has to do with vision, but it bypasses the frontal lobe, which makes sense of things. So that's why a lot of times in our dreams just don't make sense. There may be
Right.
something you start off in one place and then literally the next second you're in another
Yeah.
country or
You're
something else.
flying.
You're flying, you're doing so many things, right?
Yes.
So to answer your question, we're not exactly sure why we dream. We understand why they may come about, but we're not sure why we dream.
Is it weird if someone doesn't dream? I've talked to people who say, I don't think I dream, or if I do, I don't remember them. Is that weird?
That is not weird. So many people, some people have dream recall, some don't. A lot of times it depends on the emotional component that may accompany a dream. So certainly
Yeah.
nightmares, or if it's a concern or worry about the future or the past, those dreams tend to stick a lot with us. But whether we
Mhm.
remember a dream or not is of uncertain clinical significance at this time.
That's important to hear because I think we have a lot of people listening, particularly from our shared cultural background,
Yes,
who dreams are everything. And in a lot of cultures around the world, and right here in the United States, dreams mean everything. So it's
exactly.
always interesting to hear that, there's something we're not sure about, but if you're not dreaming, it also doesn't mean you're weird.
Absolutely, absolutely.
Wonderful. And so you talked about stages of sleep. So you said REM sleep, REM, as in Mary, and non-REM sleep.
Yes,
Do we need both? Like, can survive if they're only able to get one part of that sleep stage, but not the other? And if they're supposed to get both, what happens when they don't?
good question. So there, just to recap, so there are two main stages. You have the non-REM, as you mentioned. And REM stands for rapid eye movement. Okay,
Mhm.
and then you have the REM sleep, which is the rapid eye movement.
Right.
So you have these two phases, and the non-REM is actually made up of three stages. We call it N1, N2, and N3. N2, we spend about 50% of our night or sleep in that stage. And three is the deepest sleep. That is where the most restoration of our body cells, the cells happen. And that's
Mhm.
where the growth hormone is secreted. So then we have the REM sleep. So REM sleep stands for rapid eye movement. And literally, that's what happens. The eyes go back and forth very rapidly.
Why?
So we're not sure exactly why, but what we do know is that during that time, we're also paralyzed. So
Yeah.
except for our breathing muscles and of course our eye muscles. But during that time, we're paralyzed. And the reason we're paralyzed is when we're dreaming, if we're dreaming that someone is chasing us, we don't want to get out of the bed and literally run. You know, sometimes many of us can recall we may have had a bad dream and we're trying to feel like as if we're trying to run and get away from it, but you just feel like there's something holding you back. You can't.
Yes.
So exactly. So that's what happens during REM sleep. And yes, the two stages are very important. So the non-REM, particularly, that's where we have the restorative properties. And as I mentioned earlier, that's where the declarative memories tend to be consolidated. And then the REM sleep, that's where primarily like the non-declarative memories, those are solidified. Now, interestingly, in depression, that people who are depressed or suffer from major depressive disorder, they have significantly reduced amount of REM sleep. And some antidepressants can actually decrease REM sleep. Now, people who have decreased REM sleep, they haven't been necessarily noted to be at a significant disadvantage of that compared to people who have adequate REM sleep. But at the same time, it's still important to try to get all phases of sleep as much as possible. But if I had to, sorry, go ahead.
How long does each phase last, or should last on average?
So the entire sleep cycle lasts from about 90 minutes to 120 minutes. So up to 2 hours for each cycle. So we start in N1, go to N2, N3, and then to REM, and then sometimes it goes back to N2. But each cycle should be about 90 to 120 minutes. And then we wake up.
We wake up.
So we wake up in the middle of the night. Sorry, go ahead.
Sorry, so we actually wake up after each cycle without knowing.
Without knowing. So sometimes we remember, sometimes we don't.
Wow. Now that's important here because they're about the fact that they woke up in the middle of the night and that distressed them. You know, I woke up, so then I stayed up worrying that I stayed awake or I woke up. Why wake up?
Exactly.
That can happen, is what I'm saying.
Yes, exactly. And we call that the ultradian rhythm. So, you know, we hear about the circadian rhythm, but the ultradian rhythm, that's where we have the numerous cycles or the several cycles within a 24-hour period. So that is normal.
Okay. So thinking of all that, Doc, when people have disordered sleep, and what other things can lead to ordered sleep, and what I'm going to ask about is diseases.
Do you mind repeating that? There was an issue.
What happens when somebody's sleep doesn't follow sort of that 90-minute cycle, or they're not really getting through? Maybe they get through the non-rapid eye movement phase, but maybe for some reason it's disrupted, and they're not getting through all their phases or their 90-minute on average cycle. What can cause that? And then what happens?
Sure.
How do they feel it?
Sure. So there are several things that can cause it, right? So, you know, just certain heightened levels of arousal. So if someone, for example, has anxiety or depression, those things can cause repeated awakenings during sleep. And they can cause us to not get that deep sleep that's necessary. Another thing that can cause it is sleep apnea. Sleep apnea is where we stop breathing for at least 10 seconds or more, at least 5 times an hour. Okay.
Is that the same as snoring?
It's not necessarily the same as snoring, because snoring essentially is where the soft palate, you know, that where, and there's a uvula, the little thing we see hanging at the back of our, the top of our roof of our mouth. The soft palate where the uvula is attached to, that sort of doesn't have a good airway. So on inspiration, when we're breathing in, it sort of flaps against like the tongue and the roof of the mouth there. So that creates this sound known as snoring. However, snoring can be and is can be an indicator for sleep apnea. So that's one of the questions we ask people in screening for sleep apnea if they snore. So those are some things among several other reasons why people may have repeated awakenings or may not get the adequate depth and duration of sleep. Because in order for adequate sleep, we want to have for adults at least 7 hours. For teenagers, it's at least 9 hours, and of course for infants, it can be up to 17 hours or 16 hours. They sleep quite a bit, especially the newborns.
Wow! So you're that we really need those 7 hours or so to restore, allow the body, allow it clean the brain and heal itself, protein and plasma. But at the same time, if you're not breathing well, that all can stop, right? So sleep apnea. How does one get diagnosed with sleep apnea?
Sure. So if someone has, so to answer your question, a sleep study. So a sleep study is essentially where we have several electrodes and different apparatus on the body. We have electrodes to know the state on the head, to know the stage of sleep that you're in. There's sensors to see how much you breathe in. Also on the chin to see muscle tone. And there's sensors on the chest to see respiratory effort. Also, there's a pulse ox to see the oxygen saturations, electrodes on the eyes to see eye movement, so we know if someone is in REM sleep or not. Movement, their electrodes on the legs to see if people are moving their legs, because there's a sleep disorder known as periodic limb movements of sleep. And that actually can be responsible for waking people up. And they're not even aware that they have this disorder, which needs to be treated. But anyway, so that's how we get this sleep study. So that's like what the sleep study comprises of. And, someone goes into a sleep center, and usually they try to sleep as often or as much as they could, I should say. And then you can have home sleep studies. So that's what sleep studies are. And people simply can ask their doctor if they have significant daytime sleepiness. So there's a mnemonic called STOP-BANG, STOP-BANG. So the S stands for snoring, the first thing you mentioned. So if someone snores, if the T is for tired. So if you have significant daytime sleepiness and you're tired all the time. Because remember, with sleep apnea, you're not, even though you may not always be consciously waking up, but there are a lot of what we call arousals, where someone is sort of in a semi-awake state. It's almost as if they're awake, but they're not fully awake, and they're not getting that restful sleep. So, so if someone stops breathing, it's like, okay, we need to get this person air, and the body almost kind of wakes them up with, consciously or unconsciously to get that air. And what happens is people end up having daytime sleepiness, because even though they think they're sleeping, they're exhausted because they just keep waking up, and they're not getting that restful, deep sleep that they should be getting. And they're not aware of it during the night. So the T stands for tired. The O is for observed apnea. So if someone has a bed partner, that person may see that they actually just stop breathing. And it's very frightening for a lot of people watching that, because these people stop breathing for at least 10 seconds or more. So it can be up to 30 seconds or a minute. And people people wake them up, a bed partner may wake them up thinking, okay, are you dead? What's going on? So observed apnea is the O. The P stands for pressure. So people who have poorly controlled blood pressure or high blood pressure, that also can be an indicator for sleep apnea. And why is that? Because again, when you're not breathing, think of it as someone suffocating you. If someone is suffocating or choking you, you'd be fighting for your life. And then it releases these stress hormones called catecholamines, like a fight or flight response, because they're like, okay, listen, we got to get blood to the brain. We got to get as much oxygen to the tissues as possible. And this leaves someone in a chronic state of high blood pressure. So pressure, that's another indication for poorly controlled blood pressure, another indication to get a sleep study. So then the BANG, BMI, body mass index. So that's, weight over the height. And this can be determined if it's 35 or higher, that's an indication. Age 50 or older. N is the and it's for neck circumference. So if the neck circumference in women greater than 16 inches or men 17 inches, that's another indicator. And then G is for gender. So males tend to be more prone to having sleep apnea. But women after menopause, they also have can be quite prone to sleep apnea.
So stop, bang. So basically, look at your sleep. Are you tired? Are you having
blood pressure?
Blood pressure issues. What's your weight? What's the neck circumference? Now that's huge, because I think for a lot of us, we've never heard about the role the size of your neck, the circumference of your neck plays in your risk factor for sleep apnea. And G, guys, male.
Exactly, guys.
Yes. And of course, now, so that's helpful to know, because I'm sure there are people here, either themselves or they have family members for whom they're on multiple blood pressure medicines, or they're doing their best, they're changing their diet, they're different blood pressure meds, they're exercising, but it can't seem to get under control. What you're suggesting is that might be an indication that they also have something going on with their sleep.
Absolutely. And sleep apnea is extremely underdiagnosed. We are now getting more and more people getting the word out, and more primary care physicians are recommending it, or different other types of physicians, because it affects so many other organ systems. So, but it's very underdiagnosed. So people should have a low threshold for either referring someone for a sleep study, or patients just asking their doctors, hey, I'm snoring, I'm tired all of the time, and I have, my blood pressure is difficult to control. All of these things certainly, I'm having difficulty with my weight. All of these things can be indicators for sleep apnea. So it's important to get sleep.
Is it a chicken egg? Is it the sleep apnea leading to issues, weight issues, maybe diabetes problems, or is it those things starting and causing sleep apnea, or are we not sure?
So that's a good question. So certainly they could be bidirectional, but in terms of sleep apnea, so it could go both ways. But in terms of sleep apnea contributing or causing those things, it certainly can play a role. So as you mentioned, sleep apnea, you stop breathing for at least 10 seconds or more, at least five times an hour. So mild is 5 to 14 times an hour. Moderate sleep apnea is 15 to 29 times an hour. And severe sleep apnea is
breathing for 15 to 20 times in an hour.
Oh, yes.
That's almost 10 minutes.
Absolutely.
Oh my goodness.
And then let's not forget severe sleep apnea, where you stop breathing at least 30 times an hour.
Wow.
I've scored sleep, I've seen sleep studies where it can go up to 100 times. It's like they're just all in this constant state of just barely breathing.
Oh my God.
Say, Doc, I am exhausted. And then you treat them with the CPAP machine, which is a machine. You wear the mask and it actually provides positive airway pressure. And then they come back the next time and say, Doc, that's like a miracle. Like, I feel so much better. I have so much energy. Why? Because they're finally getting oxygen in the system. But to get back to your question regarding if it's, sleep apnea causing some of these issues such as obesity or high blood pressure, it certainly contributes. And there are a couple mechanisms by which it does this. So one is called where there's hypoxia or decreased oxygen, right? So when there's decreased oxygen, the body goes into this fight or flight mode. So it releases stress hormones known as catecholamines. And this can cause increase in blood pressure because, again, it's stressed out and it's trying to get as much blood and oxygen to the tissues. But also, what also happens is that there's an increase in cortisol. Cortisol is another stress hormone. Cortisol actually can cause, insulin insensitivity. Why is this? Because, again, when you're stressed, fight or flight, we want to run from that dog that's coming, okay? We want to run from danger. Cortisol actually decreases insulin sensitivity because insulin helps with storing the sugars that are in our blood. So when our bloodstream has high sugars, insulin says, hey, There's too much of you in the blood. It's toxic. Too much sugar in the blood is toxic. We want to get you into the cells. We need to store you as glycogen so we can use you at another time. So when the insulin does this, it decreases the amount of blood in the sugars in the bloodstream. Exactly.
Yes, you can't run.
What's that?
It's a distraction from the need to run, so to speak.
Distraction, absolutely. So we need to run. And so, but when we're in this chronically stress state, the increased cortisol suppresses the insulin. Why? Because we want that blood. If you're to run, you want that sugar in the blood, or that glucose in the blood, so it can get to the muscles. So then when the cortisol during sleep apnea or any type of sleep disturbance, which is decreased, cortisol, which usually is very low during sleep and starts to rise at about 6 a.m. in the morning. Right. But when we have decreased or disrupted sleep, that cortisol is released much earlier. And it can even start at like 3 a.m. So then when what's that?
So it starts undermining the thing you're supposed to do. You were talking about earlier, like the glycogen and all that stuff. Wow.
Exactly.
So Doc, I know there are lots of people here who have questions because this is phenomenal. And I think for a lot of people around the world, they haven't realized how important sleep is to just their function, but also disease processes.
Exactly.
So if that's the case, do you think that anybody diagnosed with diabetes, obesity, or high blood pressure should, and I know I'm asking for an opinion, not necessarily a recommendation, but do you think they should have a sleep assessment done?
Sure, it should be strongly considered because they could be reciprocal, right? One can cause the other. And certainly, for example, obesity can contribute to sleep apnea. And why is that? Because one of the main causes for sleep apnea, and there are two types. There's central sleep apnea, where your brain actually does not tell your body to breathe during sleep. And that's a smaller percentage of sleep apnea. But then the most common type of sleep apnea is obstructive sleep apnea, where there's some obstruction from the nares or from the nose to the lungs, causing an obstruction in apnea, or PNEA. Pnea is a breath, and A means without. So you have, the obstructive apneas, or not breathing.
So there could be ways, or somebody has sinus problems or a deviated septum, things like can cause obstruction from
exactly. But one of the most common reasons is what collapse of what we call the pharyngeal dilator muscles. So in our throat or in our pharynx, we have muscles which actually dilate during sleep. And that actually keeps the airway patent or open. And in sleep apnea, it's very relaxed. And that's why we need a treatment called CPAP to help open up that airway. Now, where obesity comes in is when there's excess adipose or fat tissue around the neck that helps to further cause that collapse of the already weak airway. So in that case, that's where sleep apnea or obesity may contribute or cause sleep apnea. And it's so much so that there's some people with mild sleep apnea, if they have a 20 to 30 pound weight loss, their sleep apnea can be reversed.
Wow. So just some weight loss. It doesn't need the CPAP machine, no other big intervention. I have another question for you before we go to the questions from our audience. Does sleep apnea lead to early or premature death? Maybe, my question is for some of these younger folk who we hear died in their sleep, could it potentially have involved sleep apnea?
It's possible. Usually it doesn't directly cause death, but due to the many sequelae or other diseases or comorbidities, such as heart failure, again, because if the heart has to be working so hard, to get oxygen and so many other processes that occur, there's a significant risk of stroke. It triples the risk for strokes, risk for heart attack, heart failure, as we mentioned. So there's so many other reasons that people may die from, and that's related to sleep apnea.
Sleep apnea. So it's really critical to diagnose, identify sleep apnea, and then treat it. And now we're going to get to questions, but let's talk about treatment, because I can't tell you how many people, their big complaint is, I don't like the CPAP. It's noisy. It's not cute. It's not sexy. It's not, right? So how do you convince people to not only start the CPAP, but to continue with it, the ones who are still fighting?
Sure. So, it's a struggle for a lot of people initially, because as you said, nobody wants to wear a mask. I mean, I've heard people call it like Darth Vader and so many things, and it's like, okay, someone coming over, you have to pull out this machine, or for a bed partner, it's very, or a spouse, whoever you're sleeping with, it can be difficult. But a couple of reasons. One, a lot of people who have sleep apnea snore, and the snoring itself is a huge disturbance to a bed partner. Right. So that's one of the things, and one of the reasons. And a lot of couples, they may come in and the wife or the husband said, listen, you gotta make this person wear this because I need to sleep, or I'll sleep in another room. Right.
Because that's the other thing. The bed partner can end up with disrupted sleep from the snoring of the person. Exactly. With the yes.
Exactly. But also, so then, so there's that, but also when people truly understand the significance and the seriousness of sleep apnea and all the things that it has been clearly linked to cause with, hypertension, strokes, Alzheimer's disease, right? We know that, so that's some other motivating factors. The other thing is we use initially, there's some people who simply can't have difficulty getting used to something on their face. So we have a series of desensitization techniques where, we encourage people, hey, just wear it while you're watching a TV show, wear it for 15 minutes, just get used to it. So, that's some other things. And now we have various types of masks. We have like nasal pillows, which just go into the nostrils. Okay, wow. Then we have
beta setup.
No, exactly. So just the nostrils. And then, of course, there's the apparatus to keep it there. And then we have some that just go over the mouth. But if someone still can't get used to that, there's 3 other main therapies, which I can briefly go over. But CPAP is the best. Okay, so let's just keep that in mind. But there's another called an oral appliance. So the oral appliance that goes into the mouth, and essentially it brings the mandible or the lower jaw forward. And the goal of that is to open up the airway. If you're bringing the lower jaw forward, we're opening up the airway. Now that is indicated or can be used for people who have mild to moderate sleep apnea. So if you stop breathing up to 29 times an hour or less, and certainly you have to have a good set of teeth in your mouth, or at least 6 on each row. And then there's some other indicators, but that's another option. Third option is called a hypoglossal nerve stimulator. Now, what that does, there's an electrode that goes around the hypoglossal nerve, and the hypoglossal nerve is the main cranial nerve that stimulates the tongue, and that causes it to actually move forward. So if this is the lower teeth, the tongue actually just goes a little beyond the teeth to help open up that airway. And there's a small generator that's implanted in the chest. Again, and this is indicated for people who stop breathing at least 15 times an hour up to like 45 times an hour. Now, again, it doesn't work it's not as effective as a CPAP machine, but for people who truly cannot tolerate CPAP, these are some other options.
So these are like second and last resort options for someone who failed all the CPAP.
Exactly. Yeah, if they just can't get used to CPAP, then we try some of these other options. And there's surgery, but we almost never resort to surgery currently.
So, when we did, when you went over stuff, Doc, you said, a few things that were, she said age over 50, male gender tended to higher risk factor. But I have to be honest with you, as a women's health specialist, I see a lot of patients who on screen, I'm confident, have sleep apnea, whether it's the cause of their underlying hormonal disease, their weight issues, resistance. But I see them, and I actually tend to get studied in part because of my concerns for their risks in pregnancy when you put more strain on their breathing apparatus. What do you know? Is there anything in particular that we should share with the audience here about sleep pregnancy and sleep apnea?
Absolutely. So, sleep apnea, again, we stop breathing, and I'll keep saying this, we stop breathing at least 5 times an hour for a duration of at least 10 seconds. So you're not getting oxygen. So in a pregnant woman a mother who's carrying a fetus, she especially needs that oxygen because it needs to go across the placenta to the fetus, because that's the only way the fetus is wholly dependent on the mother.
For oxygen.
So, and for oxygen, for nutrition, exactly. So the hypoxia, when that happens, that actually has been linked to decreased fetal growth or intrauterine fetal growth restriction. Okay, so that is because, again, the fetus is not getting the oxygen that it needs. Another thing with sleep apnea is that it causes release of inflammatory cells. Okay, because it's like it's this, again, this sort of.
He's trying to figure out why it's not getting the oxygen.
Exactly. So all of these inflammatory cells can actually be very harmful to the fetus because it can lead to premature birth. So the fetus is not fully developed. And again, preeclampsia, absolutely. It definitely can lead to preeclampsia, which, again, preeclampsia, for those of you who don't know, the high blood pressure, and then could cause edema. It can cause protein in the urine, which can also stillbirth. Absolutely, you got it. You're the specialist, and so and then it can also lead to seizures, eclampsia, right? So again, and then once someone gets a seizure, that significantly decreases the oxygen to the fetus. So there's so many problems that can happen with the fetus that does not get enough oxygen, including vasoconstriction. So also with sleep apnea, you have these catecholamines, or these stress hormones, which try to increase the blood pressure, but they constrict the vessels that bring blood to the fetus.
Right.
So sleep apnea can be significantly harmful to a fetus.
Very much so. And, that's why I screen for it and send patients to get the study and treatment. And I try to emphasize the patients. I think a lot of people haven't connected the two. While we have obesity amongst many younger women, and certain demographics, actually certain ethnic, over 40% of reproductive age young women are in the obesity category. So we're already at risk for diabetes of pregnancy. You couple that with pregnancy, because pregnancy itself also causes insulin resistance. The placenta makes a special protein, placental lactogen, that causes insulin resistance. And then if mom also has sleep apnea, she's really now high risk for super hard to control diabetes of pregnancy, preeclampsia, small baby. If the baby's really struggling to get blood across that placenta from all the high blood pressure and decreased blood flow, like you just described, it can lead to stillbirth. The heartbeat may stop, or what we call fetal demise. And so it's important that everyone who's listening here understands that really sleep is important, and disordered sleep is important to learn about, and to emphasize doctors to get it diagnosed so that you can have a healthy life, whether you're male or female, and if you're a mom to be, so that you can give your baby the best chance. There's also some data with epigenetics, doc. If mom has sleep apnea, pregnancy, and hypoxia, chronic hypoxia, her baby is more likely to be born with oxygen and obesity, grow up to have risk for obesity, diabetes, and stuff like that.
Yeah.
So very scary. Well, you know what? I have more questions, but I also know the audience is just jumping at the block to ask questions. So let's start. So we have Janelle Victory from London. Well done. Hello, author
Hello.
Janelle.
Hello,
Hi.
London.
How is London? It's like really late there right now, right? You guys are on Saturday. Joanne says good evening. Philomen says thanks, such good. Ashiva says following, I don't deny with a cry face. What do you have to say to her here? I believe it's a her. Yes, that's a her.
Sure, yeah. So I'm sorry that you don't sleep a lot, but we do get that complaint a lot. We do get that complaint very often. So one of the things would be to ask, as a sleep specialist, if you were to come into my office, ask several questions. First of all, exactly, what time do you get to bed, or, try to get to bed? How long does it take for you to fall asleep? How many times do you wake up at night? Because there's some people who, it's a perception that they may not get any sleep, but then we call that like a paradoxical perception where they do get some little bit of sleep, but because they're so awake most of the time, they don't recognize the sleep. So we also send you home with a sleep diary to see exactly, find out what's going on. Also habits during the day. So there's several things that can, sleep hygiene issues that could affect sleep. If someone, just simple as when someone drinks caffeine or tea or sodas, because caffeine has a 6 to 9 hour half-life. So having that within 9 or 6 hours of sleep, that can cause someone to chronically, or have to have insomnia, right? Sleep onset or sleep maintenance. Also, if someone, if there are people who may take stimulants or have thyroid medication, depending on the time that those are taken, those can affect sleep. Alcohol, right? It can help someone fall asleep, but then when it's metabolized in the liver, it actually causes a paradoxical awakening in the middle of the night. Depending on also, does someone have a regular routine where the brain gets used to, winding down at a certain time and, getting into a certain habit. All of those things we talk about. When does someone exercise? If so, when do they exercise? So all of those questions.
Is it good to exercise before sleeping or not good?
So for people who have difficulty sleeping, it's not good because, exercise tends to wake us up. It's alerting. It also increases the body temperature. And one of the things with circadian rhythms, and when we talk about circadian rhythms, we talk about that the rhythm of sleep. Circadian is 24 hours. So there's a circadian clock in the what we call the superior chiasmatic nucleus. And that actually interacts with the hypothalamus, which has to do with, controlling sleep. So then one of the, and I'll get to the body temperature in a second, but melatonin, many of us have heard of melatonin. It's
melatonin nowadays. They buy the supplement.
Yes. So melatonin is essential for sleep. It helps us to feel sleepy at night, but it also decreases the body temperature at night, which is important for restful sleep. So much so that at about 3 a.m. or the wee hours of the morning, that's when we have the lowest body temperature. So exercising actually raises the body temperature. So you don't really want to do something that's going to disrupt or raise the body temperature when you want the body temperature to be lower. So exercising earlier in the day is actually recommended. And when that's done, it actually causes a bit of an overshoot to really help that body temperature to decrease at night and to help you get sleepier in the evening in preparation for bed.
So watching your caffeine intake, sleep, temperature, watching the caffeine intake, watching the temperature, that's really good to know. Anything else?
Last thing would be a sleep study. Okay, so again, sleep apnea can be waking someone up. And not necessarily even some people may have it who may not have all of the Stock-Brown criteria. So if someone has difficulty sleeping, a sleep study is almost always indicated just to ensure that they don't have sleep apnea, because a narrow airway, especially even in thin people, may cause sleep apnea.
I remember being taught, I don't know if it's still true, but, back when this girl was in medical school, we were taught that some people actually with sleep apnea have these really vivid nightmares because it's the brain's attempt at waking them up. right? Because their oxygen is so low. Is that true? Is there truth to that?
Yeah, I'm not sure if it's as well established, but it certainly can happen because it certainly can happen. So the relationship is not as clear, but it
Okay,
certainly can happen. Yes.
it can happen. If somebody is only having these horrible dreams and nightmares, that might be another thing to talk to your doctor about. If you're not sleeping because of recurrent
Sure.
things
Yeah.
waking you up.
Exactly. Yes, and
Okay,
again, because it tends to happen during REM sleep, because that's
yeah,
the dream sleep, even though it's a bad dream, but it tends to
yeah.
happen during that phase.
Okay. Juliet says Trinidadians. Yes, Juliet.
Yes, Juliet, how are you doing?
Melville says, as it relates to people that snore but have no health issues, is that considered a sign of sleep apnea? So she's saying someone who doesn't have a diagnosis of a health disorder, but they're snoring. Should that be concerning to them at all?
Yes, it should. So because that may be the only indicator that someone may have sleep apnea. So if someone is snoring, we definitely would recommend a sleep study to confirm.
Yes. And again, some of the signs of sleep apnea in terms of daytime signs to the person, what do those include?
Sure. So we'll go over the mnemonic. It's stop, bang. So if someone is snoring, if someone is tired, the T is for tired. If someone has observed apnea, so someone sleeping with you or the bed partner actually observes them stop breathing. Pressure, high blood pressure, that's one of the indicators. The BMI, body mass index, which is obesity, 35 or higher. Age greater than 50. The N, neck circumference. In women, the neck circumference 16 or higher, and in men, 17. And then the G, guys. I'm sorry?
Inches?
Inches,
16
yes.
inches
Yes,
for women,
inches.
17. Well, guys, when Kelly was here on Sunday, I encouraged everybody to get a measuring tape to measure your waist. Oh, you should also measuring your neck.
Your neck, yes.
Yes, indeed. Oh my gosh, Dr. Wendell, Dr. Bob, this is amazing.
Yes.
More questions. We've got a lot. What causes a person to sleep for 4 hours and see so much trouble to continue? I imagine what Philomen is saying, that she can sleep for 4, or somebody can sleep for 4, and then they're struggling after that. So it sounds like they want to sleep longer,
Right.
but falling asleep.
Exactly. So, sleep is such a complex process. So there are many different factors that can contribute to that. So certainly if someone sleeps for 4 hours and they wake up, the question is, well, why are they waking up? So of course, sleep apnea, that could be causing someone to wake up. But even in terms of getting back to bed, we talked about some of the sleep hygiene issues. Is someone using caffeine, depending on the relation to bed? Are they having a nightcap, right, which can help someone to fall asleep, but then wake up in the middle of the night? But then once, if all of those check off as not being the case, some people have psychosocial stressors. So particularly now with COVID, a lot of people are concerned about jobs, getting the virus, what's happening, with life in general. There's so many changes. People who are going through stressors such as a divorce or a health issue, right? Those are some things. Some people have pain, body pain anywhere. That can cause someone to not be able to fall back asleep. Acid reflux, so GERD, that also is a notorious for causing nighttime awakenings with difficulty falling back asleep. So again, the sleep doctor would discuss what's going on when someone is trying to fall back asleep but isn't able to.
Mm-hmm. What do you say to the person who's like, that all sounds really good, Dr. Bob, but I don't know any sleep doctors? What do you say to that person?
That says what? I'm sorry, the connection.
If someone is having trouble hearing you, they believe what you're saying right now, and they actually think they are probably the type of patient who needs to see you, but they're also concerned that there's no sleep specialist where they are. How can they go about navigating? Do you do telemedicine, or is there a place they can go to look up more information, or what can they do?
Sure. So so it depends on the country. So I know certainly in the US, you can speak to your primary care doctor if there's not a sleep specialist close by. And most places have, within an hour's drive, depending on where it is. I mean, certainly there can be very rural areas in which someone may have to drive much further. But I do know many Caribbean islands, including Trinidad, they also have sleep specialists on the island, or people and conduct sleep studies. So, to do a remote, it's not really possible at this point to do a remote sleep study. But, that in terms of advice, yes, that can be done remotely. I personally, even though right now I do telemedicine because of the whole COVID-19, I do it primarily with the Veterans Affairs Hospital, even though I also teach with George Washington University Hospital Medical Center. But I personally am not just seeing, my own patients or other patients, I should say, outside of that telemedicine. But someone can perhaps ask their primary care doctor for a referral to sleep specialists. And, in most developed countries, and even, and as I said, I know in many Caribbean islands, they do have some sleep specialists there.
I can definitely think of one person in the Caribbean who does do what you're describing, which is the home sleep stuff, and then they collect the equipment and analyze what happened, did it at home. More questions. So Velma says, wow, interesting. Arlene says, good night. Just through Hewlett says, interesting topic. Mells Melville says, during the last months of pregnancy, I felt restless and could never stay asleep. Not sure why. Do you want to tackle that?
Sure. So pregnancy and sleep. So that's actually a very common complaint, and particularly in the third trimester, up to 98% of women have discussed some sleep disturbance at some point. And in the first trimester, one of the problems that contributes to that is, of course, there's increased progesterone, of course, and estrogen. But the progesterone initially can cause, of course, sleepiness during the daytime, but more so, it can cause slowing of some of the smooth muscles. So there's increase in acid reflux because, the food isn't moving as it should.
Through the gastrointestinal tract.
Exactly, the gastrointestinal tract. So that's, one of the reasons that can happen. But particularly in the third trimester, the physical discomfort of the fetus itself and so many other issues. So a lot of women complain of leg cramps, which are common during pregnancy. Also back pain. The fetal movements itself, the movements of the fetus can wake women up. There's breast tenderness, which can be contributing. Again, the acid reflux. So there's so many other physical discomforts that can occur, particularly during the third trimester, that lead to, it's a very common complaint among women. So that's probably one of the reasons why that would happen.
Dr. Bob, we didn't really talk about it. We talked about CPAP, but there are over medicines that are sometimes advertised as sleep aids. We see the classic, of one commercial where the lamb goes to bed and sleeps so comfortably, this little sheep. Do you ever prescribe sleep aids? Do you recommend them? Do you think they're just a Band-Aid, or how do you do that? How do you work your way around meds, if any?
Sure. So sleep aids, we call them hypnotics because they help people to fall asleep. And of course, they're over-the-counter sleep aids and prescribed sleep aids. So studies have shown, and large studies have shown, that in the short term, a sleep aid or a hypnotic is maybe as effective as what we call cognitive behavioral therapy for insomnia. So people who are having insomnia difficulties, falling asleep, staying asleep, or waking up too early, and it's usually associated with some sort of daytime symptoms, such as sleepiness or irritability. Those people, they've found that a sleep aid may be as effective as cognitive behavioral therapy. However, studies have overwhelmingly shown that in the long term and after about a month, most patients prefer cognitive behavioral therapy and ditching the sleep aid because it's been shown to be so much more effective and long lasting. And cognitive behavioral therapy, in a nutshell, addresses the attitudes and the beliefs surrounding sleep in order to have more restful sleep and increased duration sleep. So, do I prescribe sleep aids? I do sparingly if I think that the patient is willing to also enroll or try to get some cognitive behavioral therapy. And usually that's done by a sleep psychologist over 6 to 8 weeks. It includes things such as, not catastrophizing sleep. So if someone doesn't get the, good night's sleep, they don't spend the next day thinking it's the end of the world. People don't.
I know some people like that where if they did not sleep well last night, everybody has to hear about it.
Right, exactly. And you try to get rid of the sleep performance anxiety. So a lot of people, because they have problems sleeping, they become extremely anxious just to go to sleep. And then, we tell those people, hey, just don't get into bed if you're not sleepy. So we try to, there's several different things, relaxation techniques, whether, thinking that you're on a beach somewhere or something, also having a worry journal. And a lot of people have heard of gratitude journals, which are an excellent idea because studies have shown that when we're thankful, that activates certain parts of the brain to help us, feel happier. But also a worry journal. And you'd say, well, why do you want a worry journal?
Oh, what is that?
So people who worry or who may have anxiety and the worries keep them up at night, we say, you know what? Spend 10 to 15 minutes, if you have to spend 20 minutes, where you're just going to worry. And you're going to write down your worries, close the journal, and you're going to leave them there. That way you said, you know what? I've done my worrying for the day. I spent 15 minutes worrying. I'm not going to do this in the middle of the night. I can spend my time trying to get restful sleep. And studies have shown that has been effective. So I prescribe hypnotics, but I try to encourage going away from it if possible. Exactly.
Really good. I read that. Especially like the worry journal. I might need one myself.
Yeah, I know we all do.
Dr. Kelly Wood says, is a home sleep study as good as going to the lab, the sleep lab?
Great question, Dr. Kelly. So a home sleep study may underestimate the degree of sleep apnea. So why do we do them? So one, that it's certainly convenient because people don't have to come into the lab and people are in their home environment, because there are a lot of people who may have different times in which they fall asleep. And just because of how sleep labs are set up, we expect people to come in at 8 or 9, fall asleep, and wake up by 6 or 7. And it's sometimes difficult to find a sleep lab where someone is able to sleep throughout the day. And of course, there's sleep labs that do that for certain types of sleep studies called MSLTs. But in general, they try to get people in and out, right? But if someone has a home sleep study, they can sleep whenever they fall asleep, and we're able to test the sleep apnea. But why home sleep studies are not as effective as picking up or may underdiagnose sleep apnea is it doesn't have the EEG component. And EEG tells us that shows us the brain waves. And we use that in conventional or in-lab sleep studies to determine arousals. And arousals contribute to sleep apnea, or what we call hypopneas, which is a significantly decreased apnea, or reduction in breathing. So because home sleep studies do not have the EEG component, it may underestimate the severity of sleep apnea. However, I would say this: if a home sleep study is positive for sleep apnea, then you definitely know that you have it. But if you have a strong suspicion for sleep apnea and the home sleep study is negative for sleep apnea, then we may have to ask someone to come into the lab so that we can have that EEG component, which is more sensitive for picking up sleep apnea.
Really good. Dr. Kelly, again, is the Epworth Sleepiness Scale useful? What is that?
Good. So the Epworth Sleepiness Scale. So that's a series of 8 questions in which we ask people, their propensity to fall asleep. So it's rated from 0 to 3. 0 is no chance of dozing off or falling asleep. 1 is a slight chance of
during the
dozing off.
day or just any time?
Well, particularly during the day, but even just in general, right? But not when they're ready to sleep, but just their exactly. So 0 is no chance of falling asleep in terms of during these activities. 1 is a slight chance, 2 moderate, and 3 high chance. And some of the questions that we ask them is the chances of falling asleep if you are sitting and talking to someone, if you are reading a book. What are the chances of falling asleep if you're watching TV? If you're at a stoplight, if you're the driver and you're at a stoplight, chances of falling asleep if you're a passenger in a car for an hour without a break. What are the chances of falling asleep if you just, you're just sitting down quietly after lunch with no alcohol? So we ask a series of questions and we list their propensity to fall asleep. Usually, and it's rated out of 24, or it's graded out of 24. A score of 10 or higher indicates that this person has abnormal daytime sleepiness, and certainly 18 or higher, significant daytime sleepiness. So it's helpful.
That's like every resident, especially every OBGYN resident, will be 10 or more in that test.
Yeah, absolutely. Automatically.
And every worker in COVID-19 right now.
Yeah, exactly. Oh my goodness. So, it is helpful or it's useful just to determine the degree of daytime sleepiness. And we actually use that, or I use it from for each patient from visit to visit to see how their daytime sleepiness is being treated, particularly those with sleep apnea.
Good to know. So is that a tool that maybe some members of our audience should into just taking that test if they're suspecting that maybe...
Sure, they can just Google Epworth, EPWORTH, sleepiness scale.
Yes.
And they'll see those 8 questions.
Yes. Dr. Lee, with the knowledge here, she's helped.
Right.
So she says, I see a lot of patients who come with fatigue who think it's their thyroid. Their thyroid levels are normal, but sleep apnea screening is positive. I refer a lot of patients to sleep. Dr. Kelly is an medical endocrinologist, so she sees a lot of thyroid, diabetes, other hormonal cortisol issues, adrenal disorders. So she is affirming what you were just saying.
Absolutely.
No.
Yeah, and again, it's a bidirectional relationship. The sleep apnea may be causing some of these, many of these metabolic issues, right? And then, of course, they in turn can contribute to sleep apnea. So they definitely work together. Thank you, Dr. Kelly, for your input.
Yeah, thank you, Dr. Kelly. I also see a fair number of guys who have low testosterone, still, low energy, etc. But in screening, they also have sleep apnea. And so for them, I especially send them for testing and ideally treatment for the sleep apnea, because even testosterone, if they're not sleeping, that can lead to more mood disorders.
Exactly.
And I don't want people getting angry or moody on testosterone.
Right. Exactly.
Watching
because again, there's you remember the circadian rhythm is a 24-hour cycle. So yes, it can help to control sleep, but also the reproductive hormones, the gonadotropin releasing hormone, and it affects the luteinizing hormone, the pulsatile, the release of that hormone. So again, disrupted sleep definitely affects all of these things.
Now, I know the data is not super strong, but I've seen some data that says men with chronic obstructive sleep apnea may also have decreased sperm parameters. They may have lower sperm numbers and other semen parameters as well.
Sure. Yes, absolutely. And this could be related to cortisol as well. Dr. Manny.
Yes. Hi, Dr. Manny. I feel like your crew is out tonight, Dr. Bobb.
All right. That's right.
Dr. Smith is here. He's based in Washington, D.C. He's a neurologist, Dr. Smith.
Oh, great.
Has his own children's hospital. Louisa, thank you for all the valuable information, doctor. Kimoy says, pleasant night, signal freezing. Oh, sorry about it. It didn't look like it was freezing on our end. Somebody says, yes, signal's freezing. Joanne says, Dr. Bob, I occasionally from time to time can't sleep at night, but it's worse now. I only had 2 hours slept today. It's like my nights have turned to day sleep. What can I do to get back to a regular night sleep pattern? I do have HB. Do you know what it is?
Sorry, HV?
I'm thinking high blood pressure.
Okay. Got it.
Yeah.
Got it. Okay, so thanks for your question. So again, there's several questions that I want to find out. What time do you get into bed? How long does it take for you to actually fall asleep? How many nighttime awakenings do you have? And well, of course, sleeping for just 2 hours, that's certainly not a whole lot of time. But again, we find out all of these questions because we can use certain techniques. Of course, again, we start off with a sleep study, but then also find out what's going on. Why does this person have insomnia? And one of the things we used to treat insomnia is we tell people don't get into bed if you're not sleepy. Now, and it's sort of like a sleep restriction type tool that we don't recommend in people who have bipolar disorder because decreased sleep can trigger manic episodes.
Right.
But in general, just say don't even get into bed if you're not sleepy. Okay. And if you're sleeping, if you are in bed for more than 20 minutes and you haven't fallen asleep, get out of bed. Do something boring, really like a boring, some sort of, not something that's not too stimulating, all right? Yeah. And certainly try not to get onto electronics because electronics actually emit a blue wavelength light, which mimics sunlight. And sunlight actually suppresses the release of melatonin. So that's why, electronics at night, if we can avoid them, or if you really have to do it, use like the nighttime mode to help. But avoiding electronics at night is ideal. Sorry?
I said that's huge because I think a lot of people, when they're having trouble sleeping, they go to their cell phone.
Exactly. And Facebook, yeah, exactly.
Yeah.
So, those are some things that would be recommended. And of course, if those things aren't working, and of course, as you mentioned, some of these sleep hygiene, be sure to watch the caffeine intake. Try to avoid any caffeine if you could. Alcohol before bed. When do you exercise? All of these things may contribute. And when do you eat? Eating just before bed or within 2 hours of bed, that actually can affect, cause, decreased depth of sleep, increased nighttime awakening. So, there's so many factors which can contribute to disrupted sleep.
True. Dr. Kelly says AFib arrhythmia risk is also increased. I presume she's referring to sleep apnea, that you can have
absolutely
basically heart arrhythmia, which is changes in how the heart beats or runs, that can lead to really bad stuff, including death.
Absolutely.
Stroke. Mells, would you say that someone with sleep apnea is at an even higher risk for poor recovery if COVID positive?
Yes, exactly. Because sleep apnea, one of the things it does is that it actually suppresses the immune system. Okay, because when you have disrupted sleep, the cells of the immune system, which are usually released during deep sleep, that N3 or the non-REM sleep, that is affected. So therefore, we need our immune cells, which are specialized to fight the SARS-CoV-2 virus. And when we have disrupted sleep, those cells aren't released into our bloodstream. So it certainly can put someone at higher risk. But I would make this note on sleep apnea and COVID-19. So sleep apnea, as much as I tout the use of the CPAP machine, it actually can cause increased aerolization of a virus, or particularly the COVID virus. And aerolization is getting the virus out there into the air. So for COVID-19, we actually recommend, if you're having the main symptoms of COVID-19, or certainly tested positive, cough, cough or difficulty breathing, fever, definitely check with your primary care doctor, but stop using CPAP for now. So this is probably only time you're going to hear me say this, because if you're sleeping next to someone or with someone, we don't want that getting into the air. So for the period of time that you have it, and of course for recovery, we would recommend not using it. But also around this time,
I guess then they should isolate themselves. Yeah.
so then they certainly can do that. They certainly can do that, but again, data is coming out on this all the time, right? Because it's such a new novel virus. But that's the latest recommendation for now. Also to clean the parts of the CPAP now every day, because you may, it may be on your clothes or your hands. And we don't want, if the virus is on the machine or the hose, we don't want that getting into the lungs. So for now, we recommend that people do it every day, and also realize that people may be maybe asymptomatic carriers. So if you're sleeping next to someone and you're using CPAP machine and you have your carrier and asymptomatic, that may spread it to the bed partner or somebody else sleeping in the room. So, while it is important, and, you're hearing me talk about the importance of treating sleep apnea, and we are aware of it, but during the time of, if you do have COVID-19, it won't last forever, but for those couple weeks or so, we would recommend, but speaking to your doctor first, because there's some people, the use or discontinuing the CPAP, the effects may be a lot worse or detrimental than not using it. So it's really important to check in with your sleep doctor, but at least self-isolate, consider sleeping in a separate room from your regular bed partner.
Yes. And so Jordan Bell was asking, this is Dr. Bell, what did he just say was the best? Sleep apnea, and then his follow-up, I think this is part of it. Is there a good resource for finding a good sleep specialist in my area? Is there a society for sleep medicine, or a way to track locators in different states?
Yeah, so usually, there's the American Academy of Sleep Medicine. I think on that site, there's people who have registered. There should be a list of sleep specialists across the country. So usually that's a good resource. I forgot the first question is, what is the best? Did he say?
I think he was asking what's the best sleep apnea. He might have been asking either what's the best sleep aid, or if you're still here, Jordan, if you can expand on that question, that would be helpful. But it's either he's asking what's the best sleep aid or the best type of thing to wear for sleep.
Sure. So, to address either of those questions. So, if in terms of the best sleep aid, actually, there's not the best one necessarily. Certainly, there's some we don't recommend, like Benadryl, because that can lead to cognitive disorders, and some studies have actually shown that it's actually linked to Alzheimer's, or could be linked to Alzheimer's disease or other types of dementia. In terms of sleep aid, we don't have like the best one. There's some of the ones such as Ambien, even though they may be effective, they can have significant side effects, such as behavioral issues, or sleepwalking and doing things they don't remember, or daytime sleepiness the following day. So depending on the sleep complaint, how long people have difficulty sleeping, there's some that have a much longer half-life than others. So depending on the complaint, we tailor the sleep aid for the patient. But again, we certainly tout cognitive behavioral therapy for insomnia as being more effective in the long term than pharmacologic therapy.
Guys, we're going to bring the back, because we haven't even gotten into the sleep and children, the bedwetting, the sleepwalking, and all things that can happen. As is asked, what is best to drink sleep? I imagine she's asking about over-the-counter things, or we all see this chamomile.
Sure.
He's being marketed. Is there any to know?
So, I'm not sure if there are studies that overwhelmingly or strongly suggest a drink in particular. We certainly don't recommend, or avoiding drinks if possible within 2 hours of bed. Now, certainly water, that's fine. But be careful not to drink things that have caffeine in it, because there are a lot of teas, even decaf teas, that may have some caffeine or other alerting ingredients that can keep you up. Exactly. So that's something to, be aware of or to be cognizant of. But I can't really suggest the best drink necessarily before sleeping. But what I could recommend is a routine, right? So whether that routine is, starting to wind down an hour or two before bed, reading something, taking a shower, these things help to train the brain that, I'm getting ready for bed, and start the release or contribute to the release of melatonin.
Nice. I don't want to put you on the spot, Doc. As a fertility doctor, questions I've been asked by patients: does having intubations boost better chances of sleep?
I'm sorry, it was freezing up at that point. Having
intimate relations help you.
Sure. So, we say that the bed should be for two things only, for sleep and for sexual activity. So certainly with the hormones that are released during sexual activity, oxytocin, dopamine, these, hormones can actually help in relaxing someone or helping them to have more restful sleep. So certainly, it certainly does not hurt.
Doesn't hurt.
Can help. Exactly. Yeah, exactly.
Because of sleep paralysis, how to treat with it?
So that's an excellent question. So sleep paralysis, just for those who may not be familiar, it is where you are awake, but your body can't move. So it's a very frightening experience. And why sleep paralysis happens? So let's just actually go back to the main stages of sleep. You have the non-REM and the REM, REM for rapid eye movement. And that's where we also dream. So our bodies actually intentionally paralyze us so that we don't act out our dreams. So if you think that a dog is chasing after you, you don't want to get up and run into your wall. Or if you're dreaming that, you're in a fight with someone, you don't want to be fighting your bed partner, because there are sleep disorders in which those things do happen, where people are fighting with their bed partners or they're injuring themselves. So this is a protective mechanism to prevent us from acting out our dreams. But what may happen is in transition from REM sleep to another non-REM stage of sleep, some of this, the neurochemicals may actually overlap. So we're awake, but that neurochemical that paralyzes us actually is still there. So that's what really causes sleep paralysis. You're awake, you can see, but you cannot move. Okay. Now, how do you treat that? So first thing, you certainly want to isolated sleep paralysis in and of itself is not harmful. So sleep paralysis, believe it or not, it's not that harmful. It's scary, but it's not harmful. And sometimes just touching something or hearing a stimulus, that can actually help in getting you out of that paralysis. You also want
probably feel.
Sorry.
Now I say it feels scary.
Oh, absolutely, absolutely. And people also may have hallucinations that may go along with it. And it used to be called like the witch is riding you syndrome, because people think that it's some sort of paranormal phenomenon that's keeping them down, that's preventing them from sleeping.
True.
But
True.
It's really not. But the other thing is we want to make sure it's not part of another sleep disorder called narcolepsy. And narcolepsy is where someone has an abnormal propensity to just fall asleep. And that can be associated with cataplexy. Cataplexy is where you just, while you're awake, you have abnormal or low muscle tone in response to some sort of excitatory stimulus, such as crying or excitement.
Yes.
But it also can be associated with those hallucinations, hypnagogic, going to sleep hallucinations, or waking up, pumping. But it also can be associated with sleep paralysis. So it's important to make sure that sleep paralysis is isolated to itself, but not part of another disorder such as narcolepsy.
Wow, that's good. And that's another talk about narcolepsy.
Yes.
Heidi, what causes, I think it's the same question. Mel says, like that idea, a worry journal. Yes, Mel's. That is one of the myths of Dr. Bob has been dropping here. Lydia says, how does menopause your sleep? Yeah, Lydia, that's a great question.
Oh yeah, that's an excellent question. So there are a lot of hormonal changes that occur during menopause, right? So usually, there's, when you're the expert in the hormonal changes, but certainly it certainly can disrupt with hot flashes, right? So that's one of the causes. But also just the changes, the body just getting used to the changes in estrogen, and not having that regular cycle. Also, it increases because progesterone tends to have more of a protective effect, which is one of the reasons. In the stop band, the G is for male, male gender, because it tends to have a bit more of a protective effect on women during the reproductive years. But when those hormones are significantly decreased, perimenopausal and postmenopausal, that they can be at similar risk for men in terms of having sleep apnea. So those are some of the ways in which menopause can affect sleep.
Okay, guys, I see lots of. We're gonna have to wrap. I try to get as many as possible. Dr. Kelly says, I also believe testosterone replacement can also worsen sleep apnea. So I don't start testosterone because obstruction is treated. I agree, Kelly. I feel the same way. I feel the same.
I agree.
And parents often get upset. They're like, what's wrong with me? Just treat testosterone. Right. And unfortunately, some of them even elsewhere, because tell them, well, yes, but I really want you to get this sleep study done first. Curtis says, well, watching you now, LOL. Good, yes, that must be in reference to the freeze. Joanne says, okay, I usually go on my games when I can't sleep. I would try to eliminate technology, and that would help. This was Joanne who was saying she only slept 2 hours at night, 6 in the day.
Right. Yeah, so again, not the best, even though it's most convenient, and unfortunately, sometimes I myself am guilty of it. But again, the technology, the iPads, the iPhones, computers, TVs, these emit a blue wavelength light, and it mimics sunlight. So it tricks your brain. So what happens during a regular circadian rhythm cycle is that the melatonin is released from the pineal gland, later in the evening, maybe like 7 or 8, and it helps us to get sleepy as it decreases the body temperature. It rises and it peaks at about 3 a.m. on average, and that's when we have the lowest body temperature. And then it starts to decrease, and then sunlight actually stops or inhibits the release of melatonin. Why? Because we want to get ready to get up and work, and we need that energy and that alertness to get on with the day. So, but the electronics, this wasn't back, centuries ago, right? So we didn't have that issue, when men was coming up, or, many years ago. So, but now this is a new issue with being in this century, or even last century, with probably, well, in this century, last century, I should say. Yeah. So we don't recommend it. If you absolutely have to, try to put it in night mode, but that's still not an appropriate substitute for just eliminating electronics before bed.
Very good, very good. And another question we have, this is from Jordan. I guess I got the answer. He was referring to CPAP. I just misheard. Thanks for the additional resource information. Wonderful.
You're welcome.
Anne-Marie, good evening, Dr. Cindy and Dr. Bob, and all who are listening. Stay safe. Wonderful. Philomen says, thank you. Informative. Mells, thank you. I think most of these are thank yous. A couple questions for you, Dr. Bob. Yeah. One of them is there any merit to melatonin? There are now so many companies who market melatonin. I know melatonin marketed even to my fertility patient population now for different reasons, not necessarily sleep, but specific to sleep, and those who are maybe in search of better quality sleep, as you're saying, melatonin actually has a specific timing. You're sleeping. Does taking supplemental melatonin help or hurt?
So, good question. So it shouldn't it's important that it's taken at the right time, because melatonin, as I mentioned, it's released from the pineal gland, usually at about 7 or 8 o'clock at night, helps us to feel sleepy, decreases our body temperature. Now, there's some people in which exogenous melatonin, or outside of the body, may, if you take that about 2 hours before you're ready to go to bed, that may actually help. So we use melatonin, particularly in people who have what is known as delayed sleep phase disorder, where they fall asleep much later than societal norms dictate. But it's important for them to get up for work or get up for school, to start at 8 o'clock, 8 a.m. or something like that. And the melatonin taken about 2 hours before the desired bedtime can actually help readjust the circadian pattern, but also has a somewhat of a hypnotic or effect or drowsy effect. So certainly melatonin can help. We would recommend that it's manufactured, because the bovine or melatonin from cows or sheep, there's a risk that it may have a prion disease, and many of us have heard of mad cow.
Right.
So there's a theoretical risk. So I try to avoid melatonin from those animal sources, but manufactured melatonin may have some benefit to.
Synthetic vegan melatonin, so to speak.
Exactly.
Right. And Dr. Bobb, this has been amazing. And we've talked about so many things. We're actually coming up on 1 hour, 45 minutes. So
Wow.
for me to get to bed and all that.
To get their sleep.
If you guys, because we talked so much today, what are some of the big take-home points that you want to make sure the gets from this talk today? And for those who are just joining, be sure to go back, check it out. This is Dr. Wendell Bobb, triple board certified doctor in neurology, sleep medicine, and neurophysiology. And as you see, he knows his stuff, and that's because he studied all these different aspects of neurophysics, neuroscience, sleep. So it's really important. I really want us to talk about this because it matters so much. And although sleep and immunity did talk about that, we did specifically say this is deep and nervous system conversation, but you did talk about that. So you covered much. But what are the take-home points you would want the men, women, and people listening here today to take away from today?
Sure. So the first thing is sleep is important. Okay. It's one of those things that have been undervalued, but it's crucial. It's crucial for regular body processing and to regular body function. It's important for our memory, for our levels of alertness. It is important for adequate cardiovascular health, to prevent strokes, heart attacks, arrhythmias, blood pressure. And it certainly is important for, and to prevent some of the other comorbidities that we talk about, like diabetes. So there's so many important aspects of sleep. That's one take-home message. The other, if you have daytime sleepiness and some of those things, and the stop bang, if you snore, you're tired, you have someone has seen you not breathing in your sleep, you have high blood pressure, you're obese, BMI greater than 35, age greater than 50, neck circumference greater than 16 inches with women, 17 inches with men, and then male sex, be sure to ask your doctor for a sleep study or to be referred for a sleep study, because you may have sleep apnea, putting you at risk for some of these other disorders, including Alzheimer's disease.
Yeah.
So, that's the second take-home point. And the third thing is, just watch your sleep hygiene, which are the good habits before bed, avoiding caffeine, alcohol, if possible, a gratitude journal, but also a worry journal. If you are the type of person that tends to wake up in the middle of the night and worry a lot before bed, just get those worries in, say, close the journal and say, hey, I've done my worrying, I'm good to go. Okay. Yeah. And of course, that some people, we didn't even get to talk about meditation and different other aspects which may help people with sleep. But, so those are some of the main take-home points. But definitely bear in mind some of those things.
So if they're right now in the Washington, D.C. DMV area, they would like to see a sleep specialist, what is the recommendation? You primarily work with administration.
Yes.
But what other resources in that willing to recommend? If you're allowed to, actually, if you're not allowed, okay.
Right. So it depends. Sometimes there may be conflicts of interest. But
yes.
As you mentioned, I work with the Veterans Affairs. So I personally primarily only see veterans from that perspective. Although I do teach, the sleep fellows. I'm assistant faculty at George Washington University Hospital, but I don't see patients there. We teach the sleep fellows when they rotate through with us. Mm-hmm. But in terms of resources, again, checking that AASM, the American Academy of Sleep Medicine website, and they should have physicians or sleep physicians across the US, including the DMV, the DC, Maryland, and Virginia area.
Okay, wonderful. And so you're on social media, Dr. Bobb.
I am.
Where can you be found? I've been posting some of your contact information, but what do you share online? Where can they find you? Do you live as well? Because I noticed you have.
Yeah, so not as many as you do, but we're getting there. You've inspired me, Dr. Duke. So,
wonderful.
So that's good. That's good.
You have a lot to share. I think it's worth putting it out.
Exactly. That's important. And, again, that's one of my passions, to get the word out there. So I am on Facebook. I think you mentioned you have it there at Dr. Wendell Bobb, MD. I'm on Twitter, which I don't use very often, but I'm still there. Instagram, as well as LinkedIn. I'm most active on my Facebook, but I'm working on getting more active in other social media platforms.
Wonderful, wonderful. Guys, thank you so much for joining us today. I'm looking to make sure I haven't missed any key comments, questions, concerns. Dr. Bobb, thank you so much. Happy Friday. I know you have a busy weekend coming up for work.
Yes.
And
yes.
Thank you for taking the time. We will certainly have you back. And guys, as usual, spread the word, share the link, and send us your questions, comments, even if we're too loud. If you have questions for us, we will see you then. Until then, bye.
Well, thank you for having me. It was a pleasure.
Thanks, Doc.